So as Kathy said, my name's Ruth Martin and I'm a community geriatrician in Connolly Hospital. And Connolly Hospital covers some area in CHO 7, 8 and 9. So our aged care facilities, our residential care facilities are spread over a number of CHOs. Today I'm going to speak on the experience of COVID-19 outbreaks in our residential aged care facilities from a community geriatrician point of view. So as an overview, I'm going to go through an introduction, then a little bit about the international experience prior to our outbreaks occurring in hospital, the concept of learning as we go, then I'll talk about our community liaison team in Connolly Hospital, the Connolly Hospital response to our residential care facility outbreaks, the outbreak experience itself, and the effect of hospitalisation on our residents, and then a little bit about the recovery phase. So a novel coronavirus, severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 was identified following clusters of pneumonia in Wuhan in China in December 2019 and early January 2020. A public health emergency had been declared in February, followed by a global pandemic in March 2020. Although in 81% of people there's mild disease with no either febrile illness or a really mild pneumonia, in 14% people can get severe disease with dyspnea, hypoxia, and then critical disease with respiratory failure, shock and multi-organ dysfunction reported in 5%. An overall worldwide case fatality rate has been reported at about 2.3% so far, with no deaths among the non-critical cases. Currently, worldwide, we have over 4,300,000 cases reported, confirmed, with nearly 300,000 deaths. And in Ireland, we've just over 23,400 cases, with already 19,470 people recovered, which is good news, but nearly 1,500 deaths, which isn't. And the case fatality rate, we knew even from the time it was coming from China that it was much higher in those over 80. The Chinese Centre for Disease Control and Prevention was quoting about 20%. So we knew in our residential aged care facilities that our patients were going to be high-risk patients, not just due to their age, but also because of their comorbidities, their functional dependence. And we also knew that they were living in a really high-risk environment with high physical contact, multiple carers, and even just the concept that they were living with so many other people. The international experience, I suppose, first of all, our information came from China, where we knew there was increased morbidity and mortality and fatality rates, case fatality rates quoted as 18 to 20% in those over 80, because we knew it was more prevalent, severe disease was more prevalent in older people and those with comorbid illness such as cardiovascular disease, respiratory disease and diabetes. The first peer-reviewed article came in a residential care facility came from Washington. And so from that, we had found that in their facility of 130 residents, over 60% of them were affected and over 20% of their staff. And of those residents affected, they had 57% of them hospitalised, which would be quite different here in Ireland with a case fatality rate of 27%. But even their visitors were being affected, but obviously with a less functional decline and issues, their case fatality rate was just 7%. I think following on from this, when the pandemic hit Europe, then we started to hear some horror stories from Spain about the army being called into residential care facilities where people had kind of abandoned their work. There were abandoned residents and some of them living amongst the dead who hadn't been picked up to go to the morgue yet. And then in Italy, again, we saw these high numbers of deaths of older people with high case fatality rates greater than 80. And then, newspaper articles suggesting that not just in Italy, but in France and further afield, that the 50% of the deaths were actually taking place in residential care facilities. So it was all very worrying even before our first outbreak had happened here in Ireland. The concept of learning as we go is not something that we were too familiar with or indeed comfortable with in the medical community. I suppose we were learning a lot of information, you know, the unknown extent of transmission of pre-symptomatic and asymptomatic patients, you know, that still is an issue. We all know there's a peak level of virus at the time of symptom onset. We know if you have severe disease, you're going to have a higher viral load than a person that has mild disease. But we also know that people are transmitting the disease before they ever show any signs. And this, of course, is a worry about trying to control this. I think for staff in the aged care facilities, from what I'm hearing back, what they have found most difficult to deal with is the changing guidelines. You know, first of all, in symptoms, we know that our elderly people now have more vague symptoms. Sometimes they're just off their baseline or have a little bit off their food, have a loss of appetite, lethargy or delirium. And most of them, or well, lots are not presenting with cough, with fever, as we had expected initially that they would. Then there's also been changing guidelines in testing, who would do the testing, how the testing would be done, then our mass testing and the delay in getting results. I think also the guidelines about visitation has been very difficult, and sometimes places are opening that to interpretation. The use of PPE also has had to change when we found that there was definitely so much staff-to-staff transmission that you had to start using surgical masks in those situations just to try and prevent that happening. And then also changing guidelines about certification of death, I know has been a stressor for people working in aged care facilities. You know, I think great things have happened over the time, you know, with the establishment of crisis management teams and outbreak control teams in the CHOs. And I think now it's very clear, you know, who one calls and who one contacts, and we all have a really high index of suspicion. Everywhere has their preparedness plans and their cohorting plans, and, you know, trying to target the response and the resources in in targeted zones. And I think all of that is very well done and very streamlined now. But I think perhaps at the beginning of the outbreaks, there was a little bit more confusion about how exactly one did everything. And I think something that's been very clear over the period of, you know, the way now where, you know, we've gone through March, gone through April, and we're into May, and the knowledge that virtual reviews for these older, frail people in nursing homes does not suffice for prolonged periods of time. And I think that's something that's become clear to us. Within Connolly Hospital itself, so we've had a community liaison team for over 10 years, so I think it possibly was the first set up in the country. So there has been a geriatrician and a nurse involved in the residential care facility space for all of those years. But obviously it got ramped up at the time of the coronavirus outbreaks, and even prior to it really it was getting ramped up. So now there is daily communication with the residential care facility, with the directors of nursing, with the GPs, and really providing support, advice, and at times just empathy and any sort of help that we could give. We also developed an after-hours emergency number for evenings and weekends, so that, you know, if people get into a crisis point at those times, that they had someone that they could call. We've also had weekly meetings or twice weekly meetings with our various CHO, with our COVID crisis response teams, and I know we're lucky in that manner to have that set up so well. We also set up a COVID residential care facility clinical risk assessment tool that we brought out to the facilities when we were reviewing people, and could have, you know, staff members to fill out, so that we were discussing the same, you know, points and on each resident, so we could compare and contrast well. And then in terms of swabbing, well, first we had to learn how to swab, which we did, and then we were going out and actually teaching residential care facilities at the beginning, before the mass swabbing and everything took place. And I think with the swabbing, you know, it's so important, if people are going to do their own swabbing, that they do it correctly. And when one is doing a swab in the nasopharynx, to make sure that it's in the nasopharynx, you know, that one goes right the way to the back of the nose gently, but right the way to the back of the nose, and far in enough that you are taking a swab of the correct place, because there's nothing worse than getting, you know, the way negative swabs when you know really the person is symptomatic and likely positive. And if that does happen, the swab just needs to be repeated. Our Microbiology stepped up when they developed capacity to do their own swabbing. Now in Connolly we don't process a lot of swabs, it's 70 a day is their capacity, and so they dedicated 15 of their swabs to us so that we could take swabs and we could bring them back, we could get them processed, and then our microbiology lab would call us that night and let us know if there were positives, which unfortunately they generally were, because we weren't going to see people where they weren't unwell. We were, of course, we're doing virtual reviews where possible rather than visiting all the facilities because we didn't want to cross-contaminate, but it became clear that face-to-face reviews were still required, and so in crisis situations where there was outbreaks, many people unwell, staff unwell, if the GP was not able to be in attendance, then we stepped in and went to review those patients. We did, of course, try to do as much by Zoom and everything as we could, just as everyone else is, but when we needed to go, we did. So I guess in terms of the Connolly Hospital response, well, we were doing our on-site acute reviews when required, doing treatment plans, you know, family meetings where, you know, if the nursing home care wasn't meeting families' expectations, we were organising hospital admissions and making sure that people were admitted to hospital, because I think sometimes, you know, with COVID, sometimes people appear a little bit more stable than they are, so just ensuring that people who travelled to hospital were admitted, and then of course facilitating some palliative care referrals if required, and then follow up. During the time of the severe outbreaks, when it really became clear that the hospital was settling down and really the place that was of most need was in the community, our management team in Connolly asked, you know, what they could do, and really what I said to them is what they need is they need nurses, you know, the way they need nurses to bridge the gap until their own nurses are back. Because I suppose there was a time, I think now perhaps it's easier to get agency staff, but there was a time at the beginning where agency staff were not happy to go to a facility that had a COVID outbreak. So thus they weren't able to bridge their gaps. So there were 10 nurses that kindly volunteered in Connolly Hospital to go on a rota, and then we bridge the gap for a few facilities. It wasn't necessary only for a couple of weeks, but we bridged the gap where needed. The primary contact for the nursing home supports remains the CHO lead and will always remain the CHO lead, but we forged good connections between the leads of the CHO and our nursing managers in Connolly, so I think that was a really good thing that they did to step up to help. So I guess the outbreak experience from my point of view when one actually went to a facility was the facilities were just so changed, you know, instead of being the normal homely place with people walking around and kind of, you know, the way in the day rooms and everything, it was a much more clinical setting, much more like a hospital than like a nursing home really. And I suppose what struck myself and my colleague Siobhan Kennelly, who was out with me, was the range of illness severity. You know, there were people who were completely asymptomatic and their swabs would come back positive and we would be surprised. There were people very mildly symptomatic where there was just loss of appetite and thirst or decreased oral intake, and, you know, a real loss of independence with that oral intake. And that was something that really needed to be noted, because people that used to be independent in drinking and eating no longer were, so their care needs were just increasing. Also, we saw a significant deterioration in mobility and function. And then with the identification of those very unwell, you know, instead of having a very evident, you know, secretions and very high respiratory rates, like often we were seeing people very unwell that were very quiet, you know, with no distress, and they were tolerating their low oxygenation without any increased respiratory rate. But when you went to see them and actually went in close and examined them, a lot had signs of real perfusion issues and significant hypoxia. And then of course the high stress environment that you come across in the nursing homes, you know, a real increased workload with decreased staff, or, you know, managers trying to direct unfamiliar staff around the facility. And then the mixed experience about the use of PPE. And I think when you're on the ground and you see it, you can see that the PPE at times is not being used correctly. And I think it's just so important to keep learning, relearning how to put on and off the PPE, and don't become complacent about it, because it's just as important for the person using the PPE as the people that they're treating, especially at the time of an outbreak. I think something else that struck me was the psychological impact of this outbreak. With the residents, you know, with the isolation, the social isolation from their families, no longer having any communal areas, also the fear of illness or being unwell, and then, you know, with people with cognitive impairment trying to deal with people with PPE and just really not understanding, and nearly day on day being surprised by the fact that people were wearing masks and trying to stay with them for limited amounts of time. I think with the staff, you know, I've spoken to GPs, nurses, carers, just very upset with the whole experience, you know, not alone with residents' death and the loss of their patients and residents, but, you know, the fear of contraction of the illness, the fear of cross-infection of their own families, illness in their colleagues, difficulty with the staff, absenteeism, and then this all just leading to a really high-stress work environment. And then for the families, you know, the psychological impact on the families, you know, their fear for loved ones, trying to adapt to new methods of communication, and for their family members with dementia, their fear that they were just feeling that they had just abandoned them completely. I suppose in terms of hospitalisation, this is a query and a question that I still have in my mind about, you know, when and who should go to hospital, you know. And I suppose we've always said if symptoms can't be managed in a facility, well then that's the first reason. And then sometimes just for best supportive care. I suppose with the people that were admitted, sometimes we went to outbreaks and there were people with really high care needs where the nursing staff did not feel that they were meeting families' expectations. And so, yes, certainly there's been a couple of patients that we said we'll just send them in and we will just look after them there, even if it's unlikely that it's going to be a good outcome. I took a look at the April 2020 with the Connolly Hospital nursing home admissions. So through that month we had 57 admissions. I should say we've 16 confirmed COVID positive. There's possibly a few others that had their swabs at home and we just didn't have it on our system or have knowledge of it. We had 14 deaths over that month, 7 COVID positive and 1 further death COVID positive on discharge. So it means we had a case fatality rate of 50% for our admitted residential care facility COVID positive residents. And I should stress a few of these may have had a poor baseline, but most of these that were transferred in probably had a reasonable baseline. So their death would have been, with other illnesses, would probably have been unexpected. This is a nice resource I saw from the Johns Hopkins Coronavirus Resource Centre, and I think it just gives us a point of reflection. You know, I was saying the case fatality rate of those COVID positive admissions was 50%, but here our case fatality rate of people with disease at all is in Ireland is 6.3%, which equates to about 30 deaths per 100,000 population. And you can see we fare pretty well compared to some others. You know, the UK up the top, there's a case fatality rate of 14.5%, Italy 13.9%, Spain 11.9%, France 14.9%. So really, I think the measures that we all undertook made a real difference in Ireland, and we should be happy and proud of that. However, I don't think things proceeded in Ireland as we had expected them to. I think we had all expected initially that most of the deaths would be occurring in hospital and much less in the community, when in fact the reverse was true. There was 40% of our deaths so far have been in hospital and 60% in the community, and that's with very few dying at home. Most of these are dying in residential care facilities of one form or another. I think for a lot of our facilities, you know, within my catchment, 60% of our facilities have had an outbreak so far, and lots of them are coming into the recovery phase, and we are seeing the long-term, not long-term, I suppose the short-term sequelae of coronavirus. I think there'll be long-term sequelae at 3 and 6 months that would be interesting to monitor and see what the outcomes will be. But currently what we're finding a number of weeks after somebody has had coronavirus, we're finding really big issues with weight loss. And what are we doing about that? Well, we're recommending high protein, high calorie diets, adding in oral supplements. We're seeing a real deterioration in mobility. So trying to encourage staff to reintroduce mobilisation, sitting out, appropriate pressure relief, and then physio input where it can be expedited. Then a deterioration in ADLs and function. So obviously just over time we're hoping that with increased support and encouragement that there might be some regains in this. And then mood issues are something that is something that has really become prevalent in those, especially that had mood issues at baseline. So we're seeing a lot more anxiety, a lot of depression. And I suppose at present what we're recommending is more non-pharmacological strategies for dealing with this, and we're hoping that, you know, with a little bit of socialization at obviously at safe distances within the facility, and then when visits are allowed again, you know, at the moment most places are trying to facilitate visits through the window or visits via the iPad, but hopefully in the future they'll be able to have proper visits with family again, and this will make a difference to their mood. I thought I'd finish with this graph because I just think it's nice pictorially to show that about the recovery phase, that it really is true and happening. So kindly from one of our CHOs, they have graphed this data very nicely, and we can see from the beginning of April now to Sunday the 10th of May was the first day when those recovered from COVID outnumber all the other categories, so those that have died, those that have suspect or confirmed cases. So it really does look, you know, like we're coming out the other side and really getting into that recovery phase. But I think concerns that I would have ongoing is that, you know, we can't let complacency slip in. So in terms of use of PPE, in terms of, you know, swabbing when somebody becomes symptomatic, in terms of staff staying away if they're unwell, I think where you might not be far away from your next case or indeed your first case. So we have to just not let complacency slip in yet. We have to wait until the cases in the community are really just minimal to non-existent before we really can say that we fully recovered and that we don't have danger of it coming into the facilities again. Because once it gets in, unfortunately, it causes severe disease in lots of our patients and residents. And so then that's just some references there at the end.